I invite Dr. Balabhaskar. So, he's a professor in Department of Anesthesiology and Critical Care at WIMS, Bellary. So, a member of Publications Committee, World Federation Anesthesiologist, past National President of ISA, past editor of Chief Indian Journal of Anesthesia, Chief Coordinator for formulation of ISA practical guidelines, published practice guidelines on preoperative fasting, feeding, and preoperative investigation. Position held, he is a member of BOS for UG PG in Rajiv Gandhi University and editor of Rajiv Gandhi University for Medical Science. So, area of interest is research, guidelines, and education and stimulation. Over to you, sir.
Good morning. Thanks to both the chairpersons for the nice introduction, our own colleagues and friends. Thanks to the organizing committee and the scientific committee led by Dr. Dinesh. So it's a brilliant team. And we have got speakers from different southern zone states. Good morning to everybody and all the delegates. So we are talking about certain current concepts. That was the title given to the topic by the organizing committee. There has not been much change as per whatever you have learned in the past, but there is some change in the definition, some changes in the diagnosis aspect, and some changes in the treatment aspects. So basically, the definition would say that it is a neural crest derived tumor, either within the adrenals or somewhere in other parts of the body. And nowadays we club the Pheochromocytoma proper and the paragangliomas together. So much of the review articles and the research is on what is known as PPGLs. They are combined together per definition, but they share the same clinical features. The treatment modality is same, and the etiology per se in terms of production of the sympathetic amines is also similar. So not much difference in that aspect. And of course, the word Pheochromocytoma was first coined by Dr. Ludwig Pick. So when he exposed the tumor to chromate solutions, the reddish mass became brownish. So that was the basis of this terminology. It still contributes to a small percentage of hypertension. It's around 0.1% of all the cases of hypertension. And it is present as sporadic tumor in about 80% of them. And it can be part of some syndromes. Well known among them is the MEN type 2, Van Hippel-Lindau syndrome, and neurofibromatosis type 1. Much of it is present in the adrenal medulla, as many of us know, and 10% is the paraganglioma in other parts of the body, basically. And majority of them are benign, and malignancy is seen in up to 17% of these tumors. So normally we were fond of this rule of 10, but it is now outdated. So we were fond of asking questions, and PGs were also fond of reading and answering, but this is no longer true. The rule of 10 doesn't hold good because there is a lot of subdivisions in terms of statistics. And there are important functional considerations because the tumor secretes the sympathetic amines. We must know something about the synthesis of these catecholamines. So it starts from, phenylalanine down to tyrosine, dopa, dopamine, norepinephrine, epinephrine, normetanephrine, metanephrine, and all. So this is a whole sequence. So why we have to know a little bit about this is we are going to treat the patient based on this cycle also. One thing we have to remember is 85% of these tumors secrete norepinephrine and epinephrine combined together, or norepinephrine dominant tumors only, and about 15% of them secrete predominantly epinephrine. This is very important in terms of the management, also in terms of their presentation. So if you look at the first group where norepinephrine is dominant, they will have alpha-adrenergic effects, and they will have systolic and diastolic hypertension and reflex bradycardia. And if it is epinephrine secreting, it is basically beta-adrenergic effects. The patient will have systolic hypertension, diastolic hypertension, and tachyarrhythmias. So this is the difference, subtle difference between the two. And if it is dopamine in a minor percentage of patients, it is mainly hypotension. So there is a varied variety of presentations when you talk about this pheochromocytoma. You can look at the table, so many signs and symptoms are being seen. But typically, there is a triad which goes by the mnemonic also PHE. Palpitations and headache and episodic sweating is seen only about 40% of the patients, not in all. So don't be fond of telling this again and again. Patient can also have, pallor. They can present with anemia, Okay, these are some piece of presentation related to pheochromocytoma. So patient can present with complications in the respective organ systems. Because it is hypertension per se, patient and heart is involved, patient can develop dysrhythmias, ischemias, conduction defects, chronic cardiomyopathy, or they can present with acute Takotsubo cardiomyopathy also. That you have to remember. And because it is a hyperhydrogenic state, again it will definitely affect the insulin secretion, the glucose metabolism. They are more likely to present with hyperglycemia and diabetes mellitus. And because it's chronic hypertension, there will be contracted blood volume. The fluid and electrolyte state will also be affected. The kidneys are also liable to be affected. They can indeed present with acute renal failure or lactic acidosis. So just remember the heart, the glucose aspect, and the kidney aspect. These three are managed means you are managing the pheochromocytoma. And in fact, it can get precipitated. All the symptoms, it can be episodic sometimes. So these can be precipitated by simple physical activity, trauma, emotional stress also, and there could be multiple drugs which can precipitate an attack. So if you can see this table, you have got so many drugs here. I will not go through. Yes, there is some hypertensive episode. Right, so many drugs are there. In fact, it could be as simple as, it's not advancing. Here. Sorry for some technical issue. ಇಲ್ಲ So normally I speak about research methodology. In many places we talk about alpha error and randomization. So I always say as part of my presentation, there is always that 0.05 chance of things not being in control despite the best efforts of everybody. The organizing committee have taken so much of stress and they have done everything. Okay, everything was perfect, checked by the audiovisual group also, but suddenly there is something which has happened by chance. That is 20% margin is given across the world in all the fields. So enjoy the 20% error. It's like I speak, the mic doesn't work. I keep walking on the plane and again I slip off. It's all something by chance only. So there is a huge list of drugs which can precipitate. I said it could even be a dexamethasone which was given for PONV prophylaxis as part of induction. So even after a balanced anesthesia was given, patient in this case report developed a sudden almost hypertensive crisis. So there, of course it was managed. So when we talk about differential diagnosis, normally, so some of us, we have the attitude thinking of exotic diagnosis. So don't think about pheochromocytoma even before ruling out other common causes. Okay, it could be something related to the preeclampsia, which we were discussing in the previous session, severe hypothyroidism, or menopausal syndrome. Okay, so it's a matter of exclusion many of the times. So we have to diagnose properly. So diagnosis should be very simple because the tumor is producing the catecholamines. So diagnosis is based upon finding out the catecholamines in the urine or the plasma. So it will be taken as a plasma screening test, and subsequently as a most sensitive diagnostic test, we can have free metanephrine levels or the fractionated metanephrine levels in the urine or the plasma. So this is the most sensitive test in terms of diagnosis. But when you want to basically check if somebody has got the tendency, and if you are doubtful, you can have two challenge tests. One is the clonidine suppression test Other one is called provocative testing. In clonidine suppression test, what is done is about 300 micrograms of clonidine is given orally to the patient. After about 3 to 4 hours, you follow up upon the urinary catecholamines. So there is an increase in urinary catecholamines and serum catecholamines. It is diagnostic of pheochromocytoma. And with respect to provocation testing, glucagon, tyramine, histamine have all been administered. The simple thing is glucagon would stimulate the release of the catecholamines. Look at the level of increase. So increase would be highest in patient who has got the pheochromocytoma. And we can even talk about localization. I told you initially, an adrenal mass is more likely if the secretion is primarily epinephrine, and extraadrenal or adrenal if the secretion is primarily norepinephrine. Now, having diagnosed and overall discussed about what is the secretion, we can also think about localization for the sake of surgical access for the patient also. So normally contrast CT abdomen is performed. So any size beyond 1 centimeter it is able to diagnose. Of course, we need to give contrast to the patient. But any smaller masses less than 1 centimeter, we can always have MRI. It will be helpful in diagnosing the actual location of the patient's adrenal mass. And we have got other ones called MIBG scanning, and you have got F18 fluorodopa and other things. These should be done only when you are not able to localize with the routine MRI or CT. Still, despite this, contrast CT and MRI would be the best methods for localization of the mass. That's very important for you to remember. And of course, other investigation with our focus to the cardiovascular system, ECG, echocardiogram, then focus to the glycemic status of the patient, and focus towards the renals. So all these have to be done in the medical management part of the pheochromocytoma. So once you control the blood pressure and the cardiovascular manifestations, once you see that the glycemic control is well maintained, the fluid status is restored for the patient, okay, then only you can think about the next management of the patient. So normally this preparation takes about 7 to 14 days. Okay, and the focus of management is mainly on alpha blockade because majority of the pheochromocytoma secrete norepinephrine. So this is the basis of using this drug predominantly. And if you look at this table, we have got long-acting, non-selective alpha blockers. We have got selective ones like doxazosin, even prazosin still we use, and including a drug like urapidil, which is also available for an emergency use for the patients. And beta blockers, magnesium sulfate, and as is common now everywhere, we even talk about magnesium everywhere. Okay, it has got utility in the management of patients with pheochromocytoma. And this is a very good guideline from Endocrine Society. It talks about 3 steps of preparation. Preparation 1, you have got phenoxybenjamin, which is given at 10 mg BID for about 10 to 14 days, or alternative is selective on doxazosin. If there is no control of the blood pressure, you can add on nifedipine and amlodipine, but you need more doses of these drugs normally as compared to other set of patients. And we add a beta blocker 3 to 4 days after the initiation of the alpha blockade for very important reason, mainly because it's mainly alpha blockade. I mean, alpha agonism as part of the disease. If you give early, so patient will definitely go into significant hypotension and cardiac failure if you add beta blocker early. So how do you assess that the patient is adequately prepared pre-operatively? The olden criteria was about Royson, but it has been updated recently till 2007. It talks about no BP shall be exceeding 160 or 90 millimeters of mercury till the previous 24 hours. Orthostatic hypotension must be evidenced, but the BP should be still above 80 by 45 millimeters of mercury. ECG should be free of STT changes, and PVC should be minimal. So the definitive procedure is the surgical approach, adrenalectomy. So as is frequent, again 80% of the procedures are nowadays done by laparoscopic approach only. So it's very non-invasive. Recovery is faster, and there will be less hemodynamic changes anticipated in general. And you have got transperitoneal and retroperitoneal approaches. But still there is a problem because laparoscopy, it can precipitate. The carbon dioxide laparoscopy can cause the tumor to release more hormones. That is one of the practical risks that has been found out. And large masses anywhere. So, and you have got confusion. They also do open procedures. Robotics are there, but in less number. So which type of anesthesia, what type of drug, which has got the best outcome? We have got few studies also which are available. This is about 172 patients who underwent robotic or laparoscopic procedures. They tried to see the outcomes, including the intra-op hypertension and type of anesthesia, the beta blocker, the type of alpha blocker they are using, and for how long they have been using. They found that, in fact, the regular balanced anesthesia is better than TIVA for these patients. Then robotic, they have got very few studies, and I think I can cover up the break with the permission of the chair. Thank you. And there has not been a conclusive evidence about the robotic procedures per se. And the laparoscopy is so common. This is a study about comparing laparoscopic procedure in younger patients versus elderly patients. They found that it has been a safe procedure in elderly population as well. So our choice of anesthesia would not depend upon a fixed technique. It should be mainly balanced anesthesia. It would be, as usual, the controlled ventilation with intense monitoring. See that there is no hypercarbia in the patient. See that the patient is otherwise well fit in terms of the cardiovascular system, the glycemic status, and the fluid status. These three are very important. Then you take up the patient. This last second paragraph is very important about blood. Theoretically, yes, we need blood to be kept ready whenever there is extreme bleeding, we have to attend. But about the blood salvage, because the blood of the patient always has got still high levels of catecholamines. So if you think of pre-op collection or intra-op collection and retransfusing to the patient, there is a risk of hypertension in the patient. But in Jehovah's Witnesses, maybe this is the only option. So just, there are about 2 to 3 case reports only about that. Some of them said it is good, some of them have said it's not so good in terms of patient outcome. And the usual preoperative preparation to avoid tachycardia, hypertension, counseling, and use of sedatives. When you talk of sedatives, pethidine and morphine are to be avoided. Morphine because it causes histamine release and it can precipitate release of catecholamines from the tumor. Pethidine can increase the heart rate. That is one of the problems. Ketamine definitely no in these patients. Thiopentone, look at the fluid status and the tachycardia it produces. Desflurane, the tachycardia effect. Nitrous oxide for laparoscopic considerations, we don't want to use it. Succinylcholine and pancuronium also have associated some amount of levoegolytic effect. Atracurium, mivacurium, we have got again the risk of histamine release and precipitating the release of catecholamines from the tumor. Atropine, as far as possible, try to avoid. And we can preferably use remifentanil, fentanyl, propofol, etomidate, where you have got doubt about the volume status, you can use etomidate for the patient. CO, ISO, okay, vecuronium, rocuronium, it's okay, rest of them are okay. Dexmedetomidine also has come into picture. I can probably talk a minute in the end because it's an alpha agonist, right? So usual ventilation parameters have to be adhered to. Temperature maintenance in hyperadreneric state is very important, and positioning consideration, sometimes they put the patient prone for bilateral approaches. So monitoring, there's a whole list. Okay, we will not talk about the BP per se, but I said depth of anesthesia is very important. So ETCO2 monitoring, especially laparoscopic considerations, the neuromuscular monitoring, and depth of anesthesia per se. CVP access would be required in majority of the cases, so is the intra-arterial cannulations. This is very important for us to note. So what are the critical moments when we are trying to, I have attended to around 10 to 12 cases. So when you intubate, there is a great risk of hypertensive crisis in the patient. Tumor handling is another situation, and any later planes, if it does happen, pneumoperitoneum laparoscopic procedures. Okay, and of course, when the venous drainage is ligated, okay, the patient has problem of hypotension. So we have got risk of hypertension and hypotension. What I can say is, for hypertension, we have got a new drug, the clevidipine, so an IV calcium channel blocker, which is now referred to as esmolol of beta blockers. So such a beautiful drug. This can be used for management of hypertension. And of course, if it is hypotension, you should be very careful because already patient has got alpha blockade, there could be some bleeding, there should be hypovolemia. Patient may not respond to our regular management of the hypotension. We should give some volume expansion to the patient before the ligate, right? Then we can always try to use phenylephrine. It may respond, but if it doesn't respond, vasopressin will be the best drug for this set of patients. Always anticipate dysrhythmias, supraventricular and ventricular during the intraoperative period and manage effectively, especially magnesium sulfate has been found to be useful in combination with dexmedetomidine in this set of patients. This is very important for us, about 2 to 3 slides, because we always talk, I'll put epidural, I'll provide very balanced analgesia for the patient, but this is not been supported by evidences because it is found that they do not prevent release of catecholamines from tumor cells. Hypertension post-tumor manipulation also is not that much attenuated with epidural. In fact, they can have exaggerated intra-op hypotension. These are the risks in these patients. For example, this is a study of about 347 patients. 2 of these studies in this review said that, in fact, it can precipitate intra-op and post-op hypotension, epidurals. And we had another study with open dissection, not the laparoscopic procedure. They found that epidural is an independent risk factor for early postoperative hypotension. And this is about, again, a multicentric cohort study. What they found was combined epidural and GA was not effective in attenuating hypertensive responses, and in fact could have exaggerated the intra-op hypotension. And this is in fact the case report where they speak about multiple episodes of hypotension where they administered 35 ml of local anesthetic by lumbar epidural. So of course the dose is a matter of discussion, but you please remember epidural may not help in reducing the hypertensive episodes. Post-op care, as usual, we should be very careful. Hypertension could still be there in certain percentage, but never at that higher level. And hypotension is seen in about 10% of patients, but that could be very dangerous. So you should look at the volume for the patient and the titrate vasopressors in the set of patients and follow up with, as usual, echo and other causes. Steroid supplementation would be required where you subject the patient to bilateral adrenalectomy, and glucose management, I said there could be sudden hypoglycemia in some patients. Please monitor and manage the patient. This is the most recent one. We are talking about personalized management of Pheochromocytoma group of patients. This is because you can look at the first sentence. In fact, the PPGLs, they have the highest reported degree of heritability among all set of tumors. So there is a risk of heredity. They have said that germline mutations, somatic driver mutations, and the combination of these are more frequent, and they can affect the presentation, phenotype, the response to the drugs, and the management outcomes when you talk about this. So probably in future we are going to talk about the genetic assessment of the patient in the preoperative period itself. And this is a very scary situation. Madam was talking about COVID also. So we have a COVID patient, we have got Pheochromocytoma, and that patient went into MI. So all together. So these are the ones which can still happen in your regular practice. There is a controversy recently about whether you should indeed start alpha blockers. There are at least 2 studies, observational studies. They say you straight away take it to operation theatre, but it has not been accepted by solid proof nowadays. And even as an anesthesiologist, attending anesthesiologist, definitely we would not like to handle a patient who is not prepared. Okay, this is just for information. So what you have to remember is, now in terms of current updates, I said title wise we said we club both of them together, Pheochromocytoma and paraganglioma. They are similar in presentations, number 1. Adequate assessment in terms of diagnostic tests and localization of the mass is very important. Then alpha blocker preparation is still very important in these patients. Assess for adequate preparation with updated Roizen's criteria for the patient. Use balanced anesthesia, avoid epidural analgesia per se, basically, and take advantage of the advances in diagnosis and therapeutic aspect of the patient. And personalized management I mentioned in the end. And thank you very much. And the only thing is, I was talking about alpha-2 agonists. I did search the literature. We are talking about dexmedetomidine day in and day out now. Everywhere, oral, IV, IM, infusion, except perrectal, we are talking about dexmedetomidine everywhere. So as an alpha-2 agonist, what could be the interaction with alpha blockade, which you are using for 15 days approximately? I couldn't get much evidence. I could only assume that because it is central acting drug, but initially it can still produce a peripheral presynaptic alpha-2 agonistic effect with some hypertension. But there is no existing literature. So during the discussion time, with the permission, we can have inputs from the audience. Thank you very much.